Insight in schizophrenia spectrum disorders. And the presentation is going to be brief. We can't cover all of the aspects. We're going to try to just give you the highlights. So to start off with a simplistic definition, it's awareness of illness, its effects, or need for treatment. All right, so that just basically, do I have an illness or not? Do I need treatment? Because this area has grown in terms of research, researchers have looked at the issue of insight in a more complex way. So insight could also include understanding of social consequences of the disorder, specific signs, symptoms of the disorder, and attributing symptoms to the disorder. All right, so that's more from a research end. And then a more severe lack of insight is often referred to as anosognosia. And thanks to Eric, it comes from the Greek, without disease knowledge. And Eric's going to talk a little bit more about this when he gets to the neuroanatomical basis for it. But this is kind of the notion where folks, to everyone else, very clearly shows symptoms of illness, but they really seem to have no awareness of it. All right, so how common is a lack of awareness of symptoms in schizophrenia? Estimates vary between 50 to 80%, two different studies listed up there. So more than half of the folks that we work with on standardized measures of insight will show deficits or a lack of awareness of the illness. So just to talk a little bit about how insight relates to treatment, we know that folks who have higher insight, that's associated with better treatment adherence. So I know I'm ill, or really I know that I need treatment in some way, obviously contributes to better treatment adherence. Higher insight, unfortunately, is also associated in studies with depression, low self-esteem, and low quality of life. Right. Getting some echo, I think. Somebody have a... I think I'm echoing at some site. All right, we got it. Okay, so that's when insight is better. We see both more treatment adherence and then also some things like depression. When insight is lower, we know, so folks really have a lack of awareness that they are less adherent to treatment. They tend to be in the hospital more often and show poorer psychosocial functioning. So this has been dubbed the insight paradox. So I'm more aware of the need for treatment or have more insight, so I can have more engagement, but also more depression. And then a group of researchers, starring at others and some other researchers, have found that this appears to be moderated by stigma. So it's not insight by itself, but it's insight with stigma that seems to be the problem, where the perception that this illness is a bad thing and all the negative aspects that are often attributed to schizophrenia, which really drives the depression, low self-esteem, etc. So if an individual has insight and there's low internalized stigma, those are the better outcomes. Another way to look at this from a study by Hassan and colleagues, better insight, again, to having a psychotic disorder is related to reduced emotional well-being. However, when a measure of hope was added to the analysis, this negative relationship between insight and quality of life was reduced. And so they concluded that increasing hope in persons with schizophrenia may directly and positively increase quality of life and usefulness of insight. And they talk about a concept called usable insight. And what they mean by that is insight that allows an individual to differentiate his or her identity from the illness. So the person is not the illness, and thus maintain hope in the face of stress and symptoms. All right, so that seems to be really important there. Causes of insight impairment, I'm going to talk just a little bit from the psychology end and not in depth. And so what are the reasons that we would lack awareness of having an illness or problems? Avoidance of information about self-concept that is distressing. We call that denial. So if there's something about myself that's not very likable or causes distress, I may deny that being present. For some individuals, the psychotic experience feels so real that by saying this is a disease just doesn't make sense. It feels inadequate to match the intensity of the experience that they're having. In other situations, when symptoms more gradually onset, that it can be difficult sometimes to differentiate the psychotic experience kind of over time. It sort of gradually comes upon a person. Another area that's gotten some more recent research is metacognitive deficits and insight. So we know that individuals with schizophrenia often will have difficulties with short-term memory, concentration, and things like that. But they also tend to have difficulties in metacognitive skills, thinking about thinking. So the ability to self-reflect, comprehend one's own mental state and integrate new information, understanding the mindset of others, seeing the world from multiple perspectives, and using this knowledge to help. And I'll use one short clinical anecdote. I was working with someone in group using cognitive strategies. We were just showing individuals like thinking errors. And the individual is able to identify, oh yeah, when I have this paranoid thought, there's an overgeneralization that happens, and kind of got the error. And we moved along working on this in group, and within a couple minutes said, but I have no idea why I'm even doing this. All right, so that awareness of how this new information plugged into what they were working on was missing in that moment. All right, and so work around metacognitive deficits could be one factor that's involved with insight. All right, so now we're going to transition from the psychological to the physiological.
Yeah, so I'm going to talk about the few things that we think that we might know about the neurological underpinnings for impaired insight or for anosognosia. I guess a bottom line message of the information I'm going to tell you shortly is that impairment in insight it probably does have neurological bases. So it is not simply a person being willful, or it's less the common notion of being, quote, in denial. There's actually physiological reasons for insight impairment. This is on the right side of this figure. You see a whole bunch of ovals, and each one of those ovals is a cross section of a human brain. Starting from the bottom, the top row is working toward the bottom of the head, and each image from moving down, each image is essentially going up in the skull. So you're looking from the bottom of the brain to the top of the brain in this series of pictures. These images have orange areas, which show areas of the brain where there's increased neuronal activity. And this is increased compared to what? Compared to people with schizophrenia who have insight versus people who have insight impairment. And they were asked questions that caused them to think about, do I have an illness or not? So when confronted with information about you might have a disease called schizophrenia, these are the areas of the brain which lit up in people who have insight impairment. So the bottom line is that several areas of the brain are very active, and you can see, if you look toward the bottom of the panel, you'll see some areas where there are bright yellow spots. Those are areas in the temporal and the parietal cortex on the right side of the person's brain. Another really interesting finding is that there's an asymmetry of electrical activity between the right hemisphere and the left hemisphere. We have this notion of right brain, left brain. That's what they talk about. They're hemispheres of brain. Normally, the right and left hemispheres, although they serve different functions, they have about the same level of activity. So electrical activity is balanced between left and right side, except in people with anosognosia, in which case you will see increased activity on the right side compared to the left. Actually, I put that wrong. So I should have done the greater than sign the other direction. Sorry about that. But it's right side activity is greater than left side activity. And that finding leads to some interesting interventions. Probably not really practical for clinical use, but it shows that we're closing in steadily on the insight issue. Electroconvulsive therapy is while a person is under general anesthesia, we induce the brain to have a seizure for about 30 seconds. And following that, you'll see a normalization. So the left and the right hemispheres will be in balance electrically. And the period of balanced electrical activity corresponds to sort of an opening of a window of insight. So people who lack insight will now have better insight during this post-seizure window of balanced brain activity. The good news for future development is that you don't have to induce an entire seizure to make that happen. You can actually get the right side of the brain to slow down its electrical activity simply by infusing or irrigating the left ear canal with ice cold water. So cold ice water in the left ear, it is a bit uncomfortable. It does slow down the right side of the brain activity, and interestingly, you can open up windows of insight lasting about 20 to 60 minutes if you do this to the left ear. So maybe we'll eventually get to the point where we can have better methods of equalizing electrical activity, and it's possible with this knowledge to envision like a electrical stimulator on the plates behind one of the ears that might help to ultimately normalize brain activity. But that's a down the road thing. The bottom line is that there is a neurological basis for this. Another reason to suspect that brain activity has something to do with insight impairment is that to some extent, the impairment of insight is related to the severity of illness. So patients that have more severe symptoms of schizophrenia tend to have less insight. Paradoxically, even though they have worse illness, they're less aware of the presence of an illness. We also see that there is a weak to moderate benefit of antipsychotic medications. People who take antipsychotic medications, by and large, have a greater likelihood of gaining insight. That ability of medications to improve insight is stronger for the second generation or atypical antipsychotic medications. And amongst the second generation antipsychotic medications, clozapine appears to be the most reliable at improving insight. And just anecdotally, in my experience, which is involves considerable work in state hospital populations where there's very severe illness with usually complete lack of insight, I've seen clozapine with fairly high frequency not only restore wellness, in other words, reduce the symptoms or cause an outright abatement of the symptoms of schizophrenia, but also that goes along with much greater insight. So those are some. Altogether, again, the bottom line statement is that there's a lot of reasons to believe that insight impairment is a feature of the illness and is not simply a person being willful about it.
And coming from that basis, thinking about psychological approaches rather than it just being a willful, like I don't want to acknowledge this, working with how is the brain processing information and how do we help people learn based on what their experience is. And so I'll talk just briefly about some strategies that involve finding common ground and building an alliance, some strategies that are involved in CBT and motivational interviewing, and then just briefly mention two specific approaches that are used to work in this area, cognitive enhancement therapy and metacognitive therapy. So from just a broad perspective, and this is a common gap in our perspective, is that the client will say, I'm not ill, and then on the other side, providers, family, friends will say, you need help. Right? And we found that if we try to go at it right at the brick wall and say, you've got these symptoms, you need treatment for it, we don't really get much buy-in, and it doesn't really increase insight. So most of the approaches that work from a recovery standpoint, CBT and others, really try to foster an alliance by finding common ground. Where is the space that the client is willing to work? What are the needs, the wants, what's the meaningful value, the aspiration, the goal, whatever it is, and start there. Because if you start there and you can build an alliance there, then you have a reason to address some of these other things that may be getting in the way. Right? It becomes clearer when you slowly start there. And in terms of addressing these challenges, one of the things that cognitive behavioral therapy for psychosis does and spends a lot of time is certainly building the relationship, but also working with the person to make sense of the experience, whatever it might be. Could be paranoia, could be voice hearing, whatever it is, to slowly really try to listen and understand the experience from the client's perspective first, and then help them slowly explore it and maybe integrate new information. Another common strategy is something called normalization that I'm sure most of you are familiar with, and that's really trying to take the stigma out of conversations around voice hearing and other things by describing the commonness of certain kinds of experiences folks have, sharing recovery stories, folks who have had this illness and their recovery, and the value with peer recovery specialists is being able to share that sort of recovery story, and that's part of that process. The other way to get at it is direct training and metacognitive skills, and I'll talk about that in just a bit. This is an interesting article by Lysaker and Rowe, and they try to really integrate all the approaches and say, what do we really need to see happen to improve insight, to move towards recovery? And from the client end, the person with schizophrenia, helping them become an active agent in their recovery is critical. Developing specific self-reflection skills and what they call healthy meaning-making skills. So how do you take new information and integrate it into what you already know? On the therapist side, what's really important is to be open and vulnerable. And by this, we mean to not be the expert saying, here is the answer, but the person willing to say, I'm not sure, but I will sit with you and see if we can figure this out together and figure out how to add information. Therapists also are, and from their view, to push against the systemic stigma, the idea that, if you have this diagnosis, you should be on disability, or you should be at this agency where there are no therapists, or other certain, kinds of things, to try to push against that and really promote this message of recovery. I already mentioned know the person's view and pain first, and I know that even Aaron Beck talked about sometimes you need to actually step into the person's world a little bit and then invite them to kind of see it a little differently, but they will more likely to do that if you step into their space. And then on a skill end of things, teaching self-reflection and how to bring additional information into meaning making. And so we'll talk about just questions like, geez, what does that mean that you were able to make it in today, even though you felt really bad but you had to come a long distance, to have them reflect back like, wow, I have some resilience, I have some strength, and really begin to find ways to integrate that resilient, strength-oriented kind of self-speech. Two approaches do this as part of their training. Some of you may be familiar with cognitive enhancement therapy, and this really focuses on both kind of brain training from a neurology standpoint in terms of using computer games to improve certain cognitive skills. And then there's a very strong social skill element that's in there that works very systematically to improve social skills, but some of those social skills are social cognitive and metacognitive skills. The other approach that I have listed up there is metacognitive therapy, and this is out of Germany. And essentially what they do in their groups is teach basic skills like, it's very common for most humans to jump to conclusions at times. And they'll use examples and they'll talk about ways to catch those common human errors and to kind of help folks train to like, oh yeah, this is this kind of error, and how do I help correct this? And then extending the general skills to where the psychotic content might be. Some of their early articles were called Through the Back Door, and what it is was by finding what their goals are, teaching general skills, you can get to where the psychotic symptoms are problematic that way, rather than saying you need this medicine or you need this treatment for the voices, coming at both what they value or giving skills to help them kind of work in those areas. And so that's kind of the quick summary from the psychological end of things. This is our little summary here. Impaired insight is a feature of the illness itself. It's not willful denial. And Amador talks a lot about this in his book, which is, it's named so well. It's I'm Not Sick, I Don't Need Help. And talks a lot about understanding it in this way allows, hopefully, the clinicians to be in a space where it's more about recovery and cognitive rehabilitation strategies rather than dealing with someone who's willful. So finding common ground with clients, working to understand their pain, focusing on bigger goals and values, partnering to push against stigma, are probably the most effective starting points for engagement. And then as clients move forward, looking at some of these other very specific approaches. And that's all that I have.